Manifest squint can be concomitant or incomitant or paralytic. Concomitant is non-paralytic, cause in high refractive errors and cataract and visual axis conditions. Incomitant is paralytic. Diplopia is maximum when looking at the affected side of the muscle, and extraocular muscle disease like thyroid, myasthenia, myositis are the other causes. Treatment of thyroid eye disease, systemic steroids and radiotherapy. Ocular myositis, inflammation of extraocular muscles. Next is congenital esotropia, present by 6 months of age. Large angle of esodiation more than 30 prism diopters. Management is prevention of amblyopia followed by squint correction and prevention of binocular vision. Next is accommodative esotropia, usually onset is 2 years. Next is sixth nerve palsy, that is incomitant esotropia. Congenital exotropia presents before the age of 6 months. This is congenital exotropia. Intermittent exotropia, most common divergence strabismus in childhood, usually occurs before 5 years. Management of squint, whether it is unilateral or bilateral. On removing the cover, the right eye squints, that is unilateral. On removing the cover, left eye squints, that is alternating. If it is temporal light reflex, it is convergent, and nasal light reflex, it is divergent. So center of pupil corresponds to 0 degree. Pupillary border 15 degree. Between pupillary border and limbus 30 degree. Along the limbus it is 45 degree of squint, and 33 centimeter is the testing distance. Normal reflex is symmetrical and slightly towards nasal side. Patient has left divergent squint with alternate divergent squint. He has undergone right eye lateral rectus recession and medial rectus resection, and he doesn't have Worth-Ford dot test failed, loss of binocular single vision. Even though he is color blind, his Worth-Ford dot test he is showing only 2 dots in the both eye. Right eye abduction is limited. Rest of the ocular movements are full.
And upon uncovering, the right eye takes up the fixation. So this is left divergent squint. Now I will measure it with the prism bar. So I will, so this is on Hirschberg, this is approximately 25-30 degrees or about 40 degrees. So I will put the prism bar and do the alternate cover test. And I will note the point where the deviation, where there is no movement of the eye. लाइट को देखिए, लाइट को देखिए. Perhaps his VN is 6.9, so slightly.
To perform this test, place the Maddox rod on a trial frame and ask the patient to look straight at the center of the modified Thornton chart, which is kept at 40 cm. The chart should be illuminated through the center, and patient should be asked to look at the light. Please remember that Maddox rod contains a parallel plano-convex lenses, which reflect light rays so that a point source of light appears as a line or the streak of light. And this line is seen perpendicular to the axis of the cylinder. When Maddox rod is kept vertical, it makes horizontal line, and when it is kept horizontal, it will make a vertical line, which you can see clearly in this picture. When Maddox rod is kept horizontally, it is showing a vertical line. While performing the test, ask the patient to point the line seen by patient on a modified Thornton chart. The line seen on the chart is the phoria present in the eye. Here patient pointed on 6 exophoria. Now you need to stimulate accommodation with minus lenses, either -1 or -2 diopter sphere, to check the accommodative convergence. Here we use -1 diopter sphere, and the stimulated phoria came out to be -2 exo. The change in the phoria from without any lenses to -1 diopter sphere came out to be 4. Since the -1 diopter was used, therefore the AC by ratio was 4:1. Okay, let's understand again with a new example. What will be AC by ratio when Fourier changed from 6 exo to 4 iso with -1 diopter sphere? On the modified Thornton, you can clearly see the change is at 10, hence AC by ratio will be 10:1. Again, if you would have used 2 diopter as a stimulation, it would have been 10:2 or 5:1.